for the next.
Uhuru Kenyatta amesimamisha kazi jaji wa mahakama kuu Stephen Chitembwe na kuteua jopo la watu 7 kumchunguza jaji huyo kutokana na madai ya ufisadi na matumizi mbaya wa mamlaka yake. Jopo hilo litaongozwa na jaji wa mahakama ya rufaa Mumbi Ngugi na litahitajika kuchunguza
Oh.
Good evening. We shall start at 7:15 to give time to those who are joining. Good evening, everyone. My name is Nabila. I am a BBYI member and I will be your moderator for the day. I want to first of all thank all of you for coming to this meeting. And it is my honor to invite our speaker for today. That is Dr. Flavia Ogutu. She's a gynecologist and she's going to be taking us through postpartum care. So, Daktari, the floor is yours. Feel free to introduce yourself.
Hi, Nabila. How are you doing today?
Hello.
Hi, everyone. So my name is Dr. Flavia Ogutu. I'm an obstetrician gynecologist based in Nairobi. I'm also a co-founder at Gynetics Kenya. I think you've met some of my other colleagues, Dr. Swabra and Dr. Mwangombe. So today we're going to discuss postpartum care. Just a second as I share. So we're going to discuss postpartum care in different settings and different topics in terms of the definition. So what we, just a second as I share. I may have to come out and come back in. Is that okay?
Yes, it's totally fine.
Okay. Hi, Nabila.
Hello. Hello, Daktari.
Saying host disabled participant screen sharing.
Okay, let me fix that.
Can you all see my screen?
Yes.
All right, so I can go ahead. So today we're going to talk about postpartum care. As I said, I'd introduced myself. So we're going to discuss it in terms of how do we define postpartum period? What are some of the changes that occur in the mothers after delivery? What are some of the complications? What are the things that we follow up a mother while they're in the ward? How long do we keep them in the ward? What instructions do we give them when they go home? When do they see them? Okay, we can also have questions at the end. So I'll start with the definition. So postpartum begins after delivery. So once the baby is born, that's the period from birth to about 6 to 8 weeks after delivery. So there's some, like the Americans take it up to 12 weeks because they say it may take up 2 to 3 months for your body to go back to pre-pregnancy state. And in terms of some of the changes, so anyone who's ever been in a labor ward or a delivery room, the first thing that we notice about the mothers once they deliver is that they start shivering. So about half the mothers will shiver after delivery. We still don't know the exact cause of that. It could be because of a fall in the body temperature after labor, or even some of the medication that we give to a mother after delivery to try and especially control the bleeding. And then we also noticed that a mother after delivery, her uterus significantly reduces in size. So that's what we call uterine involution, usually after the baby is out, and then after the afterbirth, which we call the placenta is out. And the purpose of that uterus reducing in size is to help reduce the bleeding after birth. So for someone who's never delivered before, it's important to let her know that she'll bleed for a while, maybe about 3 to 4 weeks, and that blood will change in the different stages. So we'll start by, we call it lochia. Lochia is the blood that's lost after delivery, the bleeding that the mother has after delivery, and divide it into 3 types. The rubra, so rubra just means red. So it's the initial bleeding that happens. It will be red to brown and will last a few days, maybe a bit heavy. She may change 4 to 5 pads a day. And then she'll notice that the blood will now become more watery, more pinkish, and that could last anything to 2 to 3 weeks. And then the last one is usually a yellow-white discharge. So it's important to tell a mother after delivery that she'll bleed for about 4 weeks. And many times, depending on the day when she's active or she's been out and about, some days the bleeding will be a bit heavier than what she's used to. But there's a certain instruction we give her in terms of if the bleeding is too much, like she's changing more than 10 pads a day, it's quite heavy, she's feeling dizzy, then that's a problem. That's something that she should either alert the nurse in the ward, or if she's home, she would need to seek care at a health facility. Other changes that occur are the breast changes. So some mothers at birth may not, when they deliver their babies, may not have milk. So you may find that the breast may still be soft without any milk. But sometimes we give medication, or even just the act of the baby pulling on the breast will bring in milk. So it's also important to let the mother know that she shouldn't have her breast so full, because then she should alternate the breastfeeding between one breast and the other one. And if she feels like the milk is still a lot, there's still room to pump and store, because once the breasts get too full, then she's at a high risk of getting an infection, which will present with fever and a lot of pain in the breast. Of course, the mother after delivery will lose some weight, the weight of the delivery of the weight of the baby. The placenta also has weight, the amniotic fluid. She also retains a lot of fluid during pregnancy, so there's a physiological weight loss. So we say routine maternal care. So Kenya being what is, we usually have the Baby Friendly Initiative. And in the Baby Friendly Initiative, we recommend that a mother needs to be roomed in with her baby. We recommend that the crib should be near the mother, such that the mother is with the baby as opposed to having the baby in the nursery. So sometimes it depends on the hospitals. Some hospitals are stricter with this than others. So most public facilities are very keen on rooming in. But you find in the private facilities, there's more of the baby staying in the nursery. So it's important that the mother rooms in with her baby. It's important for bonding. It's also important for initiating breastfeeding. So the act of the baby being on the breast and the act of the baby pulling on the breast is what brings in the milk. Another important part in terms of routine maternal care is monitoring, especially in the initial period after delivery. So you'll notice after delivery, the midwife, the nurse will immediately take the mother's blood pressure to check if her blood pressure is normal, because blood pressure, even if it had been normal before, could rise at the point of delivery. Also to check if the blood pressure is too low. So a mother who's having bleeding after delivery, which is excessive, could have her blood pressure drop. We also check the mother's heart rate. Also will give us a sign of whether everything is okay, if it's too high or too low, and also check her respiratory rate and her temperature. The other important thing is to assess the bleeding. So once the mother has delivered, we deliver the baby, we deliver the placenta. The placenta is the afterbirth, and we ensure that the placenta is complete. And that's important because that's one of the causes of bleeding after delivery, if the afterbirth is not complete. The mother may have a tear at the point of delivery, and you find that at the point where the tear is, you may need stitching. And before the stitching, then this patient may be bleeding. So we need to assess for something we call postpartum hemorrhage, which is excessive bleeding after the delivery of the baby. There's some mothers who may need to have other laboratory tests done. There are those who, for example, they bled a lot, or even before the delivery, the blood level was low, that someone needs to repeat their blood level. check for any signs of infection, which we would check with a blood test looking at the white cell count. So there's some, so during antenatal care, we usually assess and need to know what the mother's blood group is. So mother's blood group can either be positive or blood group negative. So the mothers who are blood group rhesus negative, at the point of birth of their baby, the baby's blood group is also checked. And if we find that their baby's blood group is positive, then these are mothers who would need to get an injection called anti-D. And that should be given within 72 hours of delivery. And that's important for future pregnancies. That's part of some of the routine maternal care that we give. So most mothers may not escape a tear. So they may either have a tear at the point of delivery of the baby, or the doctor or the midwife may have made a cut at the point of delivery to allow the baby's head to come out. So how do we take care of that? So one, there are those that require the tears in the we call it the perineum, are usually graded, grade 1, grade 2, grade 3, it depends on the grade. And if there is any repair done in that area, there are certain things that are important in terms of taking care of that region. One, we usually talk about sitz bath or squat bottle. So that's really just trying to keep that area clean and dry, because the most important thing in terms of taking care of any cut, any tear, is perineal hygiene. That includes keeping it clean and dry, showering twice a day, changing the pad often, because the pad is a wet surface on the place that has been stitched. So changing the pad as often as possible, but not necessarily waiting until the pad is full. Eating a high fiber diet, because for ladies, the vagina and the anus are very close together. So depending on how far the tear went, it's really important that when you go in for a long haul and pass stool, to keep that area clean so that it doesn't come into contact with stool. And so a high fiber diet is very important, because we don't want her to be forcing stool, and that would cause the stitches to come open. Plenty of water and stool softeners. So sometimes we routinely give stool softeners so that it makes the mother's process after delivery easier. And of course, pain medication. So pain medication all depends on how much pain the mother is in. We start from anything as basic as a Panadol or a Brufen, or things like diclofenac. Sometimes we go to very strong painkillers, but those are the usual medications that are given for mother after delivery. So we've talked about pain management. There's a whole spectrum, and it all depends on the kind of tear she's had, the kind of pain she's in, and how she's responding to the medication. So this is an important part of postnatal care, especially if this mother delivered by a cesarean section. There's a way we give the medication to allow her to be able to be functional, to be able to be moving about, and we de-escalate it as the pain reduces. So postpartum care covers both mothers who had a normal birth, which was a vaginal birth, and those who had a cesarean section. So all those people are in the postnatal region. So how do we take care of the scar? So we've talked about the tear of a mother after delivery, after a normal birth, but after cesarean section. So routinely, what we do is that after the cesarean section, we usually put in a dressing for about 3 days, so that to keep the wound covered, to keep the area clean, to keep the area dry. And usually we'd keep the patient in the ward for at least 3 days if there are no complications. At the point of discharge, then we would remove the dressing, and then we would spray an antibiotic spray, just like a dressing to cover the wound. But she goes home with the wound open. And we keep it clean and dry. So that means we're showering twice a day, wiping the area, patting the area dry. And for some doctors give like an antibiotic that you apply along the scar, others don't. It's not absolutely necessary. So keeping the area clean and dry is the most important thing. And she needs to be seen in the hospital after 2 weeks to be reviewed. And usually by that time, the skin should have come together very well. So that's that the doctor or the midwife is able to pick up any complications as early as possible. So how long does a mother stay in the ward? So it's individualized. It really depends. It depends on whether there are no complications or not. So vaginal births, we generally keep mothers in the ward between 24 and 48 hours. Again, it depends on the facility. So we find that public facilities are usually, I don't know to say overpopulated, so the patients are many. So we find that most mothers would stay at least 24 hours. So we'd like to keep the mother 24 hours, and that time we'll be able to assess whether she's at high risk of bleeding, and then she'll be discharged Cesarean delivery usually recommended at least 72 hours. These are straightforward delivery without any complications, or mothers who do not have any other conditions, for example, high blood pressure or diabetes that would keep them longer, or that their babies do not have any complications. So this mother, we've decided that she's stable, that she can now go home. So what are some of the danger signs that we inform them of as they go home that they need to watch out for, that would bring them to hospital before the expected date of clinic? So one, bleeding. So you can have excessive bleeding in the initial 24 hours, but you could also have bleeding that occurs later. And it could still be because of an infection. It could be because of, remember we talked about the placenta, and the placenta, the afterbirth has to be complete. So if there's any part of the placenta that is left, it could still cause her to have bleeding. So if she notices that she's excessively bleeding, she's changing pads very frequently, she's feeling tired, she's feeling dizzy, and that's something that would need to bring her to hospital as soon as she can. Fever is also a sign of an infection, and that's important that she would need to come to hospital. And then urinary symptoms, for example, that's also talking about in terms of signs and symptoms of an infection. Breast, we talk about engorgements. When the breasts are very full, they're tender, she can actually get an abscess which is a collection of pus in the breast. If she gets any chest pain or one-sided leg pain, especially at the calf, that could be a sign of a clot. So pregnancy and the period after delivery makes someone at high risk of getting a clot, and that's something that she needs to watch out for and come to hospital as soon as is possible. And also, we always forget about the mental health of the mother. So we need to look at this mother and see, is she at risk of postpartum depression? So, and maybe that she may not be able to say it herself, but it's also important in case she brings up that she's having, we'll talk about it a little later in terms of some of the signs that would put someone at high alert that the mother may be going into postpartum depression. So at the point of discharge, we get a lot of questions about activity. So when can I resume sexual contact? What activity should I avoid? When can I start driving? There are those who say, when can I start exercising? So we start by saying, first, resumption of activities is when someone is comfortable. Of course, post-cesarean or post-normal delivery, we tell the mother it's important for her to walk. Walking is good. It helps her in terms of her recovery. But we say avoid heavy lifting. In the initial period after delivery, especially the mothers who are post-cesarean section, because of the kind of medication that they're taking that could make them drowsy, we would avoid that. And also the tension that is applied on the scar with the prolonged sitting. We get a question about resuming sexual activity. We always say that it's when the mother is comfortable and she's ready, but at least after 6 weeks, that allows that if she'd had a tear, that it has healed, she's been reviewed. If it's a cesarean scar, it also has healed. And after, we have given them contraceptive advice, because remember that there's still a chance of conceiving even if she's breastfeeding. So another important factor in terms of postnatal care, postpartum care, is contraception. And this is a conversation that is important to start sometimes during the pregnancy, even when she's in the ward as she goes home, and then when she comes in to review for clinic. So there are certain contraceptives that are recommended for a mother who's breastfeeding or who has a newborn infant. And it could be a permanent method. So what I've written here as BTL is bilateral tubal ligation, which is a permanent method of contraceptive, where we tie the tubes of the mother to prevent her from conceiving. It's usually considered a permanent method. It can be done either post-delivery, normal delivery, or post-cesarean section. So that's an option that can be offered to her even before she goes home. The other one is the intrauterine devices, which we usually call the coil, which is inserted into the uterus. So that can be done, usually can either be done in theater, for example, after delivery, there's a specific one that we put, or we do it at 6 weeks when they come in for their 6-week review. And then in terms of hormonals, what is recommended are the ones that have progesterone-only medication. I know you had an earlier talk, I think last month, on contraceptives. So the progesterone-containing medication are what we call Depo, which is the 3-monthly injection. There are progesterone-only pills, which are everyday pills that only have the hormone progesterone. And then we have something called implant, which is Implanon or Jadel. So Implanon is a 3-year progesterone-containing contraceptive, and Jadel is a 5-year contraceptive. So usually chosen depending on availability and how long the lady would like the contraceptive. And breastfeeding also confers some form of contraception, but it's not 100%. So we always recommend that even for as much as she may be exclusively breastfeeding, she needs to be aware that there are other options as well to ensure that then she doesn't conceive or she still has a small baby. So this is a very important conversation to have with mothers after delivery. And that conversation should start during the pregnancy, after delivery, and when she comes in for the reviews in the clinic. So you've discharged her, you've given her the danger signs. So when should she come back for clinic? So generally after cesarean section, we recommend a review after 2 weeks. And the purpose of that is to look at the scar, to be sure that it's healing well, it's not opening up, she's not gotten an infection, she's not bleeding. Or if you've had a vaginal delivery with complications. So you could have had an extensive tear that maybe had gone all the way to the anus, and you need to review that. Or maybe it's a patient who had diabetes or hypertension and you'd need to want to follow up, or heart disease that you need to follow up in the clinic after 2 weeks. But most uncomplicated vaginal deliveries usually seen at 6 weeks, where many times we'd combine the clinic of the mother and the baby, so that the baby also will be coming in for their 6-week review, checking of the weight and vaccination. You'll have a topic later on immunization of the baby. So what are we looking at? Whether where the stitching was done at the perineum is healing well, whether the scar is healing well, whether she has enough milk, whether there are any signs of engorgement. We check her blood pressure, because blood pressure can still rise even after delivery. As we talked about earlier, we need to talk about contraception. Another important part that we don't always highlight, but it's important, we need to screen for postpartum depression, postpartum blues, and also intimate partner violence. And of course, immunization, which is concurrent with the baby. So we've talked about the normal, what happens after a normal delivery or after cesarean section. So what are the complications? What are we monitoring? What are the complications that we want to avoid in this postpartum period? So some of the important ones that are very common in our setting is hypertension. So you could find that there was a lady who had high blood pressure during the pregnancy, and maybe it worsens after delivery, or it could be that she got high blood pressure after delivery. So we never forget that even after delivery, there's a chance of having high blood pressure, and can be quite severe to the point where there's loss of consciousness and having convulsions. Bleeding, we've really stressed about it, postpartum hemorrhage, because we should not lose a mother from postpartum hemorrhage. So it's important, first of all, to be able to diagnose it as early as possible. And there are a number of medications that we give, and most midwives and doctors are quite good at trying to manage bleeding in terms of medication. And if it gets really bad, to go into theater to try and control the bleeding. Another important complication that can happen after delivery is what we call pulmonary embolism. Pulmonary embolism means that you may have formed a clot. Common site of clot formation is in the leg. And that's why we were talking about that some of the things that we need to watch out for is if a mother has one leg swelling. So after delivery, a lot of mothers will have leg swelling, usually of both limbs, that usually resolves after 2 weeks. But when you find that it's one leg swelling more than the other one, with a lot of pain at the calf and any chest symptoms, and that's something that needs to be highlighted, and we need to investigate to be sure that she's not forming a clot, because these are some of the causes that can make us lose a mother after delivery: hypertension, hemorrhage, chest pain. Other complications that we would need to watch out for are infections, again, very common. It could be of the breast, it could be of the wound, both at the tummy where the cesarean was done, or where the stitching was done after the delivery. It could be a UTI. The infections are something that we also need to watch out for. A lot of mothers will have pelvic pain that happens from pregnancy into delivery, sometimes also dependent on the delivery position and muscle pains. So we need to check out for that. Some ladies get urinary retention. Urinary retention means that they're not able to pass urine. So they try to go to the washroom, but urine doesn't come out. And so dependent on when they have retention, there are certain things we do. For example, we put in a catheter. A catheter is used to empty the bladder just to give her relief, but it's usually self-limiting. But she may also have incontinence. Incontinence means that she's not able to control her urine or stool, and that can also be transient, or it could be due to maybe an unsuspecting tear that may have gone all the way to the rectum. Or,
I'm sorry, Dr. Flavia.
yes?
Sorry for interrupting. Let me
Yes.
just say, tell people to please mute themselves
Okay.
once they come in. And I was kicked out. Could you kindly make me the host that I may, yeah.
I mute them all at least?
Yes, yes.
Okay, that's better.
Thank you. Yeah, thank you.
So we're talking about some of the complications. Another complication that can happen after delivery is we get a lot of sexual dysfunction. So some of these are some of the topics that we don't usually discuss, but it's important to ensure that the environment is conducive for this to share. This is more common that we can discuss at especially the clinic setting. So this is common post-delivery, both post-cesarean section or post-normal delivery, sometimes a bit more with normal delivery. Sometimes there could be a lot of trauma at the point of delivery in terms of going through the whole process of birth, the tearing at birth, the repair, the healing, and sometimes the healing may not be very straightforward. There's all the postpartum mood changes. You have a new baby, you have sleep deprivation, you're tired, you're not eating as well, you're not taking care of yourself as well, you're overwhelmed. There's also a lot of low libido after, a lot of fatigue. So it's important then to have this discussion. And that's why many times we tell the mothers, resuming of sex is at comfort. There's no date for it. We don't say 6 weeks and then they can resume. It also depends on how comfortable she is about it. So this has to be a conducive space to be able to discuss some of these things. So sexual dysfunction. Another thing is mental health. So you'll have a talk later as well in terms of postpartum depression, but I just wanted to bring it up because we don't, we just dismiss it as a mother is tired or she looks tired. But you also have to just investigate, especially when you get a feeling that the mother is depressed, she doesn't seem interested either in what is happening around her or the baby. She's losing a lot of weight. She's not sleeping or she's overly sleeping. She's very agitated. She feels worthless, like she's not being a good mother. She's not concentrating well. She may even be thinking about thoughts of death. So if she has a minimum of 5 of these symptoms and they've been present continuously for at least 2 weeks, if you're not maybe capable of handling it, it's important to be able to at least pick it up and refer her to a health professional, because postpartum depression is something that happens. Postpartum psychosis. There's also blues, but the difference with blues is that it is transient. So they may be sad, crying, irritable, but it's usually self-limiting and resolves within a few weeks. But when you find that these symptoms are persisting and correspond to some of these signs that we see, then it's important to then try and get this history and refer them so that they can get adequate support. Because a mother after delivery needs a lot of support in terms of she can't manage it alone. There's a lot that's going on. All right, so that was my talk today, to talk about the postpartum period, the things that we are going to watch out for, what signs and symptoms will tell us that something is wrong with this postpartum period, how often we should see the mothers, and very importantly, to pick up when there are issues as early as is possible, not forgetting about postpartum depression, and also intimate partner violence. So if you pick up something that that is going on in the room, for example, between a couple that you suspect, you can try and find a way of separating the couple so that you can get as much history as possible, so that in case she's in a situation that is not safe for her and the baby, then we can try and find a way of helping her. Thank you very much.
Thank you very much, Dr. Flavia. I have personally really enjoyed the lesson. I have learned a lot, and I believe we all have.
Thank you.
And it was quite well put, brief and to the point. I'd like to invite any questions. You can kindly raise your hand and we'll give you the space to ask the question. I can see one hand is raised. Veronica Judith. Do you have a question? Veronica? Go on. I think she has unfortunately left.
Okay.
Anyone else with a question, feel free to ask. Any comment as well is welcome.
Seems the participants feel like I covered it adequately, I hope.
Yes,
You
I
have
could
any?
also, I personally don't have any questions. I just want to comment on one thing I also found interesting. I found out that there's a difference between the postpartum blues and postpartum depression. So they can be differentiated in that the depression which requires at least 5 of the symptoms stated, while the postpartum blues is usually mild and includes crying, exhaustion, and may resolve within 2 weeks. It's quite interesting.
Yes, because blues sometimes is actually expected. You can imagine you're caring for an infant who's sleeping 2 to 3 hours and is up, you're constantly breastfeeding, like your entire focus is on this child that you have to take care of. So it's a bit overwhelming. So blues is something that does happen. You can find a mother is overwhelmed, she's crying, she's sleep deprived. So it's a possibility, but it's important to note when it has gotten so severe that now it is postpartum depression that may require further intervention, may require medication and other interventions just to keep the mother and also the baby safe. And that can happen to anyone. There's no one who is immune to blues or depression. So then as anyone interacting with a postnatal mother, it's important to be able to note when something is wrong and help them seek care, because they may themselves not notice that. Like, I don't know how to use the word spiraling, that they're getting worse and worse.
Yes, well noted. I can just point out to Esther Mwende. Do you have anything to add? Any comment? Esther Mwende, do you have any comment? Okay, I think everyone is satisfied and I believe the notes can be made available for further reference.
Okay, Nabila, I can coordinate with you and send them to you.
Thank you very much. And is it possible to make me co-host or host so that I may send the attendance list to the participants?
Please show me where to do that.
Okay.
Or direct me where.
Okay. There's you can go to my name
Okay.
click on my name, either clicking it or right-clicking it, I'm not sure, and see whether one of the options that comes is make host or co-host.
Make co-host, okay.
Yes.
Right, done.
Thank you. Okay. I think you're free to leave, Daktari, as I coordinate with the rest how we can make sure the attendance is taken.
All right. Okay. Thank you so much. Thank you, everyone.
Very
Have a lovely evening. Okay, bye.
You too. Bye. Okay, good evening, everyone. I am looking
Good
for the
evening,
chat.
Nabil. How are you?
I'm well, thank you. How are you doing?
All is well. That was a fantastic presentation.
Thank you. I agree. It was really well put and brief. I'm sure everyone is tired as well. It's already, bedtime for some people, maybe. And I am trying to look for the chat box. It's my first day moderating. I can't find the chat box, but I've taken screenshots, so I know who was present during this meeting. So I will kindly ask if you can just bear with me for today, and I will text in the main group for the BHMC cohort. And once you get the message, you can just reply to me and I will send the attendance link. Is that okay?
Yeah, that's okay.
Yes, Nabila, it's okay.
It's okay.
Sawa. I'll also just post the screenshots again in the group so that you can see your name. If you have any clarification, feel free to reach me. Yeah. Terry, I can see your hand is raised.
Yes. Hello, Nabila.
Hello.
Can you get me?
Yes.
Okay, so I was kindly requesting if you could talk to the ones who are in charge or in charge of the program. If maybe you could get the new timetable, the new schedule, so that we'll be able to plan ourselves accordingly.
Okay, I will look into that as soon as possible. I'll tell them today. Yeah.
Thank you.
Nabil, just a comment. In future, when a presenter is doing presentation,
yes,
kindly let's have someone to be the host also, and the host should be able to mute and unmute everyone at will. It's very unfortunate that some people take these classes like I don't know how to put it, because it's very unfortunate. You plan for a class and then you join the class and deliberately there's a noise in the background. Even if you are the presenter, you yourself who is doing that, how will you feel when other people, everyone is on the background making noise and you're doing presentation? So my request is moving forward, as long as you are logging in and the presenter started, let's have the host be able to mute and unmute. You only unmute the people who want to ask question or make comment. Because I believe some of them just join and then go do their work and then they forget that they have joined the meeting. So you can hear kids, you can hear all sorts of nonsense in the background.
I completely agree. And the only reason I wasn't able to stop that was because I was kicked out due to poor internet connection. But I will definitely make sure that that is looked into, and I will inform the speaker as well. And next time I'll also be able to mute people. It's very annoying, and we'll definitely work better on that. So kindly let us all also make sure that we are muted once we enter the meeting. Okay,
Okay,
I think
I guess it's
that
good
is
idea.
it.
Okay, thank you, Nabila.
Yes.
Thank you, Evie, and everyone. Okay, hi, everyone. Okay, thank you for the
Hi,
comments
Marcy.
and everything. I will share the new timetable. We'll be having our sessions on Monday, on Tuesdays, Wednesdays, and Thursdays, unless otherwise. We are trying to ensure that we finish this session before July, so that we graduate before July. You know, July there will be hit of the campaigns, and we don't want to interfere with, we don't want the campaigns to interfere with our classes. So we'll try our March best. We finish by 16, and for July we'll have graduated and we'll have a certificate. We are still planning on the physical or hybrid graduation, which we are still thinking about it. About the attendance sheet. We are using the Leo Club, the Leo Club Zoom. That's why we couldn't get the chat box, but we are enable the chat box, and we'll have the attendance sheet and we'll all sign. Okay, about the muting of the participants. We'll be muting everyone, and then you want to speak, you just raise your hand up or you just chat on the chat box. Thank you so much. Concerning the graduation, we are going to have a pitch. Hope everyone is preparing. I've heard that group 7 is not working, so we are going to dissolve that group and have members join other groups. Okay, the active members, and that's one person only who has just reached out and is going to join group 2. Have a blessed night.
You too have a wonderful night. Bye.
You too. Everyone may leave now.
Thanks, guys, for praying for me. I was sick. I've been discharged.
I'm happy to hear that, Edwin. Okay. Quick recovery and have a lovely night, everyone. Good night.